First of all, I thank the API group for involving us and for this particular lecture. After that exhaustive review, I'll try to stick to probable basics of CAR T cell therapy. So this comes under the concept of immunotherapy. So if you look at the various journals which was published, 2013 was the breakthrough year for cancer immunotherapy. So why is immunotherapy important? What are the arms of immunotherapy? So the first concept of immunotherapy originated from stem cell transplant. That was way back in the 1960s. So what it exactly does? So you have body, you have T cells, cancer fighting mechanisms, and the cancer predominates when the fighting mechanisms are unable to do that. So you try to harness what is there in your body and try to fight the cancer. That is basically the concept of immunotherapy. So the stem cell transplant, so you're giving allogenic or another person's strong immune system to a person who has a cancer, and the strong immune system will fight the cancer. That is the concept of hematopoietic stem cell transplant to begin with. There are a lot of cells involved in our immunotherapy. One is a natural killer cells. Then came the concept of immune checkpoint inhibitors. So what it basically does, so you have a cancer, there is an environment around that cancer cell. And that environment is what prevents the normal cells from attacking or preventing the cancer to spread. So if you block that particular mechanism, that is the immune checkpoints, you can ask the T cells or the NK cells in our body to fight the cancer cell. So that is the immune checkpoint inhibitors, which is very commonly used in nivolumab, all these in Hodgkin's lymphomas. A lot of immunotherapies there in solid and hematological malignancies. The monoclonal antibodies, that's the first concept of immunotherapy. So you have heard about rituximab. So rituximab is a molecule against anti-CD20, which is on the B cell cancer cell. So that is one of the first immunotherapies applied. And moving on, we have a lot of immunotherapy options. The T cell immunotherapy is what basically is CAR T cell therapy. So it is always good to remember the pioneers who thought before us, who led us to this development. So these are three stalwarts in the field of CAR T cell therapy. The first one is Dr. Selig Gizar from Israel, Dr. Carl June from the University of Pennsylvania in US, and Dr. Maxwell Sederlein from the Memorial Sloan. So these are the pioneers who had the concept of T cells and how the T cells could develop against as a cancer fighting mechanisms. And it's a good history to understand. So this is not something which happened over a 5-year period. The research into CAR T cell therapy happened way back in the 1980s. And the molecule as such was approved in 2017. So 20 to 30 years of research is behind this concept. So this is our poster girl for cancer CAR T cell therapy. She is, at that time, 2011-12, she was 6 years old. She had a B cell acute lymphoblastic leukemia, and which had relapsed and became refractory. The doctors told her, the family, that you have a survival chance of 6 months, you can go for a palliation. That is when the team from Dr. June and the Memorial Sloan intervened. They told, okay, we can try this concept of T cells because it has been proven in certain adult patients that there could be some benefit. And okay, they went ahead with this CAR T cell concept at that point of time as a clinical trial protocol. That is in 2012 when the survival chances was less than 6 months. And this is her today, 15 years later. A patient who could not survive for 6 months is surviving now thanks to this form of therapy. So this is the story behind CAR T cell therapy, and we'll go into what exactly they are. So the basic concept, if you look at the cell differentiation, there is a pluripotent stem cell which divides into myeloid and a lymphoid stem cell. From the myeloid, you have the natural killer cells and the T and B cells. Sorry, from the lymphoid cells. From the myeloid, you have the megakaryocytes, the red cells, and the monoclonals or the monocytes. So what is CAR T cell? It is chimeric antigen receptor T cells. What are these chimeric antigen receptors? So basically, these are autologous T cells. So our own T cells are harvested. They are genetically modified. And these T cells express a particular receptor on the T cells, so that these receptors go and attach to a cancer cell which has the marker for that. So that our own T cells are engineered to modify to fight the cancer cells. So how is it different from other forms of cancer therapy? So our conventional chemotherapies, these are like you hit hard. You don't know what you're hitting. You're hitting the normal cells, you're hitting the cancer cells. But in CAR T cell therapy, it is very directed. So you have a B cell cancer which expresses a particular marker, and this T cells go and selectively attack those markers expressed cancer cells. So the toxicities are less. It is not that it is without toxicities. So the cytotoxic effects are more or less similar to the newer immunotherapies. And it can also be combined to the latest form of therapies called the BiTE therapies. So I wouldn't go into what exactly they are. So I said the research started way back in 1980s, and it took 2017 to get the first approval worldwide. And the first approval was based on the kid, the Emily Whitehead story, which I mentioned, that the product is called Chimera. And now at present, 2025, we have 7 approved CAR T cell products, and all are in the field of hematological cancers. There are a lot of research happening in solid tumors, other malignancies, but the approvals and the research and the most evidence is for the hematological cancers. Why? I'll come to that later. So how does a CAR T cell fight your cancer? So one, the T cells has a particular marker, and the cancer cells which express these markers are targeted. So once that target is identified, it causes lysis of the the antigen positive cancer cells. That is mediated by a lot of proteins. The T cells secrete granzymes, perforins, which damages the cells. It also modulates. So one of the most important difficult aspects in treating a cancer is the tumor microenvironment. So the tumor behaves in such a way that it makes its surroundings safe. It doesn't allow anything else to come and attack it. So this CAR T, to a certain extent, modulates your microenvironment and sensitizes the tumor stroma to lysis. And sometimes some CAR T cells can also affect antigen negative through apoptotic mechanisms. Antigen negative cancer cells are also attacked. So there are now 5 generations of CAR T therapies. So the research has shown that by increasing the domains, you have 3 or 4 concepts. So you have a cell, there is a marker, so there is an extracellular domain, there is a hinge area, there is a surface membrane or a transmembrane receptor, and there is an internal membrane. So you get something from the external, through the transmembrane, it goes into the inside the T cells. The T cells, once the signal is received, it attacks, it starts proliferating. So once you modify these structures, you can increase the potency of T cells. You can also ask the T cells to be more persistent in the system so that they fight the cancer. So CAR T cells are basically called a living drug. So once you infuse, that is a one-time treatment. And once it attaches to the cancer cells, it goes on fighting throughout the memory of the T cells happen. So these are the unique benefits of CAR T cell therapy. It's a single shot therapy as compared to multiple chemotherapy treatments we give over a period of time. The most important thing is the story which I told. The person who had a survival chance of 6 months, a refractory disease, a refractory leukemia, refractory lymphomas, we don't expect them to survive more than 6 months to 1 year. Those patients, if delivered a CAR T and if it works for them, they can be given a drug which is curing their disease. So it can be tried in persons who have a refractory leukemias, lymphomas, and certain myelomas. And does it replace all the pre-existing therapies? Definitely not. So there are situations where CAR T cells fail. So those patients may still need a transplant. So this can be used in addition to or after or transplant, depending on what patient you choose. The other most important thing, the current concepts of CAR T, whichever is approved, is based on patient's own T cells, autologous T cells. So autologous T cells is your own T cell, so it doesn't cause you any harm once it is infused back to you. There is no problem with something called as a GVHD or anything, which is seen with the transplant. So this is the basic concept. So you have a patient who is identified for CAR T cell therapy. Usually the current indications are a refractory lymphoma, B cell lymphoma, a refractory B cell ALL, and multiple myeloma. So you identify this patient, you give a treatment to hold the disease, you isolate the T cells. That is a procedure called as apheresis. You cut through a vein and get the cells out, and the machine will filter out the cells for you, from which you select out T cells by identifying the CD3 marker. Once the T cells are identified, these are sent to a lab. where it is genetically modified by using a viral vector. And once the viral vector integrates with the T cell DNA, it expresses a particular receptor for which you want to target. That T cells, the viability of these are assessed. Once it is found that it is good, these are cultured and they grow into millions of T cells. These T cells are packed, cryopreserved, and sent back to the treating center. By that time, the patient would be ready to receive it, and they are infused just like you give a blood infusion. And this, once infused, it goes into your system, targets the cancer cells by expressed markers, and they start doing their job of killing the cancer cells. So what are the targets which are currently possible? As I said, it's for the B-cell malignancies. So CD19 is the most important marker which is currently expressed in most of the B-cell malignancies. So CD19 targeted CAR-Ts are the most common in the lymphomas and the leukemia spectrum. And for the myelomas, you have something called as a BCMA targeted. So these are expressed on the plasma cells. So I wouldn't go into this. So I would like to wind it up pretty fast. So the approved CAR T cell therapy, these are all in the West. So what I would like to say proudly at this point of time, 2023 October, we had our Indian CAR Ts which are approved. So usually any treatment which happens in the West comes to India maybe 20 years down the line. This particular treatment has happened within 3 to 4 years because of an excellent innovative research started from TMH Mumbai in collaboration with IIT. So we have 2 approved CAR T products as of now in India, and which is approved basically for B lymphomas, which are refractory, and in acute lymphoblastic leukemia for the pediatric childs, it will be soon approved. So the most important thing is to identify the patient, see whether the patient is fit. So as for any aggressive procedures which we do like a transplant, the basic fitness, the performance status, the neurocardiac and the pulmonary fitness, and assessing the disease status is also important. So the first step is a T cell harvest. So your own T cells are harvested and they are modified into the lab. So the next is, once the T cells harvested, they are modified in the lab by using a viral vector, and these are again cultured and expanded in the lab. Once this is adequately delivered or adequate quantities of T cells are isolated, then it is sent back to the treating center, and the vein to vein time, which means you isolate the T cells and they get back to you, that is roughly around 2 to 3 weeks. And by this time, the patient would have been conditioned well so that he's fit enough to receive a treatment. You have to understand that you're treating a very refractory disease. So there could be chances where you lose the patient within this time. You isolate the T cells, you get some 3 weeks. Between this period, you have to maintain the patient alive. So that is with some sort of alive or treatment therapies called as holding chemotherapies or immunotherapies. And once it is received, it is cryopreserved, which means it is kept at minus 180. And then you store it in the cryobank. And once the patient is to be infused, you thaw it and infuse it. So this is the treatment which I was referring to. The patient has to receive some sort of treatment so that the disease is not very aggressive when the patient is about to receive the T cells. Otherwise, you are landing into serious complications in terms of toxicities. I will come into the toxicities later. This is the preparation which we do for the patient so that his non-isolated T cells are not there causing more harm. So this is called the lymphodepleting therapy, that is to immunosuppress the patient to receive the T cells which are modified. And then you infuse. The infusion is usually a single time infusion. There are certain CAR T products which are infused in a layered protocol, like you give a small dose upfront, increase the dose and the final dose. That is to prevent certain complications called as CRS. So in India, the 2 products are there. One is as a single dose, the other is as a layered dose. So I'll delve into some of the common adverse effects associated with CAR T therapy. So the 2 important toxicities are, one is called the cytokine release syndrome, which is just like any a septic shock. It can mimic a septic shock. It occurs in almost 90% of the patients. So you have to be ready in your unit with a particular drug called as an anti-interleukin 6 blocker, the tocilizumab. Without that, you can't do a CAR T cell therapy. So that is one thing you have to be aware of. The next is neurotoxicity, where we will call our neurology colleagues to assess us. So this is basically like a seizure. Patient can become confused, they can hallucinate, and 40% can develop seizures. So this has to be identified and prevented at the earliest point. So the common symptoms of CRS, just like fever, chills, hypotension. So we have a grading system for that. So if the patient goes into shock, it is a stage 2 or 3 CRS. So the earlier identification and even prophylaxis is the most important thing to be done to prevent CRS. So the usual onset of CRS is during the immediate infusion. It's usually within the first 1 week of giving the infused product. So it is always clinical diagnosis. The laboratory can support you in terms of marking for interleukin-6, other inflammatory markers. But most of the time it is very difficult and confusing in this particular patient who is immunosuppressed. So those will be on neutropenic sepsis protocols, but tocilizumab should be tried upfront in most of these patients. So I would skip all this. The next important toxicity is the neurotoxicity. We call this as a ICANS, immune cell associated neurotoxicity. So it is a spectrum of disease which can starting from a confused aphasic patient to a somnolent or a patient who has a refractory seizures, ultimately leading to death. So all these complications which I mentioned can lead to death. So identification and early treatment is the most important. In respect to CRS, here the treatment of choice is steroids. So tocilizumab doesn't have much of a role here with adequate anti-seizure medicines. Infectious consideration is there for all our hematological patients, because these patients are through multiple lines of therapy, and with their immune system will be too much depressed. So the other important thing to understand is most of these patients will require IVIG replacement, which is to be continued post infusion of CAR T therapies. That is to prevent infections most of the time. And these patients require a long-term follow-up to monitor for late events of CRS, neurotoxicities, infections, and secondary complications like hematopoietic malignancy. Second malignancy is happening later. So this is another late complication which is called as HLH. We all know what HLH is. So immune cell toxicity mediated HLH is a different entity. It is also managed in the similar lines of HLH with steroids and interleukin-1 receptor blockers. So this is a very fancy world. Everybody is behind CAR T therapy, but it is not the final answer to your patient. There are areas where we fail. So there are a lot of limitations in CAR T therapy. One is the toxicities. The tumor response may not be as you expect. In a refractory disease, the response can be as good as 50% to 60%, but still it gives a life of hope. Your cancer is always more brilliant than what you design. So they can always escape by an antigen escape mechanism, and that can further lead on to tumor coming back. Sometimes your body is not good enough so that it doesn't traffic to where it is supposed to. And the tumor microenvironment always plays an important role. So concluding, CAR T cell therapy is a novel, excellent management strategy for refractory B-cell malignancies and multiple myeloma. It is in phase 2 trials for a lot of solid tumors. It is not a conventional treatment, but it's the newest form of immunotherapy, and it can be used in conjunction with transplant to save a life in many aggressive diseases. The side effects are very unique, and it requires a very excellent practitioner experience and expertise to treat the disease. So it offers a ray of hope for many of patients who don't have a hope at that point of time.